And this is a small but nice group. It's rather a workshop than a presentation tonight. I'm glad to be here. Welcome everybody. I will talk about opioid dependence basically because I have tomorrow another presentation on alcoholism, so the focus of my presentation tonight is treatment of opioid dependence. You see a starter picture from the Bavarian and Swiss Alps. We really have snow at the moment. It's snowing even in Munich where I live. Also, it's really cold and it's very nice to be here at the Mediterranean. A few words about epidemiology and how opioid dependence is viewed in Germany and Central Europe. A case report in the beginning about Christiane F. Until the 1960s, heroin and other opioids were basically unknown, and the first opioid-dependent individuals were seen in the 1970s, and it came to the public mind when a film of a child prostitute, a young woman, was released based on a true case of Christiane F., 14-year-old at that time, with children from Bahnhof Zoo, it's in West Berlin at that time, and she was a heroin-dependent young patient, and she's still alive, and what happened to her on the long run is quite symptomatic for what is happening to a lot of opioid-dependent patients. Christiane F., who is now in her mid-50s, both of her parents were alcoholics. She got famous, I must say, following this movie in 1981, but she's still an addict. She's now in her mid-50s. She had very brief phases of abstinence, and now she is in long-term treatment with an opioid maintenance program, methadone. She's still using cannabis quite frequently. She has alcohol problems, has a liver cirrhosis related to alcohol probably, and the only child she has is in custody, so still a chronic and rather tragic case on the long run. What do we know about alcohol dependence? I showed this slide before. These are the diagnostic issues in very brief in ICD-10 and in DSM-4. Substance abuse or misuse and dependence are defined. Dependence is a mixture of different criteria, both on the psychological, the somatic, I smile for a moment to get the perfect picture, and biological parameters. If 3 of the symptoms are fulfilled, that's it. If 3 of the symptoms are fulfilled, the diagnosis of a dependence disorder can be seen. In DSM-5, the terms misuse or harmful use and dependence have been given up, and now a dimensional concept has been adopted. The substance abuse disorder is viewed as a continuum, and there are 11 criteria for this kind of disorder. If you have 2 or 3 of these symptoms fulfilled, it's a light disorder, 4 or 5 symptoms, moderate disorder, and 6 or more of the symptoms, you have a severe substance abuse disorder. Whether this makes sense or not remains to be seen, but it's really a new diagnostic concept when we talk about substance abuse disorders. As I said, 6 or more in the last 12 months would be a severe disorder. I will skip this. How is the current situation about drugs in Europe? I could talk about that all night. First of all, there are enormous number of new drugs on the market. There are many new, but mostly synthetic psychoactive substances. About 500 have been released last year into the black market, but mostly synthetic cannabinoids, synthetic cathinones. When it comes to overdose death, most of the overdose deaths are still attributed to heroin, of course. It has a great role in this respect. About 7,000 individuals die each year as of following heroin overdose. The numbers have a little bit increased in the last year. Nobody knows exactly why, maybe it's the higher age of the opioid-dependent people, maybe it's a higher degree of purity of the opioid, nobody knows for sure, but the death rates have been risen, and among this, heroin still plays a very significant role. The number of opioid-dependent people in Europe is about 1.3 million. Half of them are in opioid maintenance treatment, as a significant number. And in the US, also about 1.2 million individuals. In the US, there's an epidemic of opioid prescription drugs. As far as we know, in Europe, that's not the case so far, but that remains to be seen whether this will come or not. In general, the opioid consumption in North America is much higher than in Europe. Not everybody who takes a drug gets addicted, but the risk is very high in heroin. It's very high in tobacco as well. It's not so high in alcohol or in cannabis, but in the opioids, there's a very high risk of becoming dependent once consumption has started. That's what the numbers I said, and there are very different figures about the risk of high-risk opioid dose in Europe. The country where the most deaths on opioids can be seen is in Estonia, one of the Baltic states, where heroin is unknown. They all die for fentanyl or other opioid prescription drugs, so a wild range of different patterns all over Europe. The most cases seen in Central and Northern Europe. Now that's more the pathological side, and the high risks states are especially in the north. Okay, now heroin dependent in the 1960s, basically heroin. In the US, there's a new generation of heroin users. For some years it looked like there was a decrease in heroin consumption, but now it's increasing again, and it's not only the black or pop people who take heroin, but more and more people from inner cities, whites from suburban cities also take heroin, so there's a widespread new area of heroin consumption in the United States. A brief look into cannabis. Cannabis consumption is very prevalent. About 20% of adults once in their life try cannabis in Switzerland, where I lived for long years, even a little bit more. For the last 12 months, about 5% of adult population takes cannabis, not on a regular basis, but at least once a year. Cocaine prevalence is lower. It's about 1% of adults. About 0.5% are dependent, and the same for amphetamines. That's what I said before. The number of opioid prescriptions is rising in the United States, as is the number of people who abuse opioids there. There are some nice figures about costs, social consequences of drug abuse and other disorders. When it comes to a burden of mental disorders in males, alcoholism is the most expensive disorder. Most missing working place days are related to alcoholism. In women, it's the unipolar depression, by far the most expensive disorder. On the 5th place, it's drug abuse disorder. So alcoholism and drug abuse play a very great role when it comes to burden of mental disorders. This is one of my favorite slides from the year 2000, a JAMA publication, and this was related to causes of death, not disorders per se, but causes of death in the United States. Which conditions make people die or get sick? And it's quite interesting to see. Most people die from consequences of tobacco consumption. That's not a surprise. Heart attacks, cancer, and so on. Tobacco has, for the public health, an enormous role. Second frequent disorder is poor diet and physical inactivity. That's the McDonald's diet. Either you don't move and you eat too much. A lot of people die from that. Third most frequent reason for dying is alcohol consumption, liver cirrhosis and other disorders. Then other disorders, and also at least on the 10th place it's drug dependence, illicit drug use. So substance abuse disorders and related disorders for public health play an enormous role. Who will get addicted? Question for a psychiatrist, who will get addicted? And there's a lot of research for ages going on here. Now, a lot of things play a role in this respect. First of all, it's the drug itself. Some drugs have a high abuse liability. As I said before, when you try heroin, you have a fairly good chance to get addicted. In alcohol, it's not so frequent. The availability of the drug plays a significant role. It's easy to get to be an alcoholic in Germany. It's not so easy in Saudi Arabia or other countries, but it exists. But the availability of the drug plays a great role. The individual predisposition plays a great role. I will talk briefly about genetics. We know that genetics for alcohol and also for other drugs have a strong impact. 40 or 50% of the liability is related to genes, but it's a polygenetic disorder and no single gene can be made responsible for that. Personality disorders play a role. I come back to that in a minute. And of course, social circumstances, the microcosmos of life, families plays a role. If both parents are alcoholic, you have a fairly good you have a fairly good reliability to get an alcoholic yourself. A few words on the individual risk of becoming an alcoholic. There's a very nice long-term study initiated in the late 1930s in the United States, in Harvard, in a year where John F. Kennedy, therefore he is on this picture, was in Harvard as well. This was a study on the long-term outcome of young men. What happened in this year, in 1938, the head of the local health service at Harvard, Arleigh Brooke, had the idea to look into happiness, who gets happy in life and who not. And in this study he included 268 healthy, normal male students who had rich parents who could afford Harvard at that time, good family background. This was financed by a sponsor. They measured all they could at that time on the somatic level, but also on the psychological level. There were also already some psychological markers, and they were screening in all of these patients, and they looked at them for decades. For this sample of young people was followed up for 60 years, lifelong. In the 1960s, the sample was taken over by George Vaillant, who also published a book on that sample, Triumph of Experience. It didn't have a theory. They just measured what they could. There was no hypothesis behind it, and looked at the people over the next decades. Results in brief, also young men with a very good family background. A third of them had some mental disorder in their lifetime. It's not depression, other disorders. Also in this sample, many individuals had some form of psychological distress. There was some psychological, also 10% or so had alcohol problems in their life. And when they looked back at the psychological data they had, they didn't find much. And the MMPI, still existent at that time, didn't show much. People who had somehow higher scales in hypomania or psychopathy had a slightly higher risk of getting alcoholic, but all the other psychological variables they measured didn't show much. So there is no alcohol personality, no drug personality. You cannot really define on psychological domains who will get addicted or not. Depression, for example, was not a predictor for getting dependent. Also, it is difficult to measure and define substance abuse risks on the individual level. What's the long-term outcome of drug dependence? unfortunate in every case. This is a picture of the Rolling Stones. I've read the autobiography of Keith Richards, 700 pages, about 350 of them are on drugs and drug experience. Also he made it, but a lot of people don't make it. And there are some very nice longitudinal studies on people who are opioid dependent. This is a sample studied in California over decades. And as you can see here, there's an enormous rate of people who die young. Many of them, in the United States data, are in prison at some time because of their drug abuse or because of criminality. Abstinent on the long run, about a fifth of individuals. It's even a little bit optimistic to my opinion, but it's not much more than 20% who get abstinent on the long run, and some are in methadone treatment. So prognosis is poor in many individuals with opioid dependence. For the reasons people with opioid dependence die today? What are they dying of? There are so many disorders. They have HIV, hepatitis, suicides, and so on. But if you look at long-term studies, and this is a beautiful paper by Louisa Degenhardt, a meta-analysis about people who die, they die from drugs still. Also, over 50% of drug-related deaths are due to drugs, mainly heroin. That's still the case today. 26%, enormous number, die from injuries, 13% from suicides. This is the bulk of reasons why they die from other disorders, cancer, HIV, and so play a minor role. Drug-dependent people still die from drugs, so to keep them in life means we must reduce drug consumption. They also have a very high comorbidity with psychiatric disorders. I talked about this in the afternoon already. There are different sample studies, but they have a high comorbidity, especially with depression and phobias, but also with personality disorders. Either way you look at it, there's a high comorbidity with psychiatric disorders in those individuals as well. There's a wonderful study from the US for the comorbidity of psychiatric disorders in drug-dependent people, and as you can see here, enormous rate of anxiety disorders and obsessive-compulsive disorders and others. In many cases, before the people get addicted, but in some cases, the chronological relationship is the other way around. So first, in most cases, it's first the psychiatric disorder, then the substance abuse, but it can also be the other way around. Genetics, a few words on this. There is not much research on the genetics of opioid dependence. The topic is just popping up now. There's a lot of data on alcoholism, but not so much on opioid dependence. There has been a fairly recent paper by Gelernter and Kranzler, American colleagues, who have looked into a large sample of opioid-dependent patients, and they made a big genetic study in some thousand African American and European American samples, a huge sample study. And what they found out in brief was that they had a high association with potassium channels. Nobody knows what this clinically means, but there was a high association with the genes coding for potassium channels. Nobody would have associated this with the risk of getting opioid dependent. So we will see whether some new pathways for the potassium and calcium signaling channels will emerge from this data or not. But to date, no fixed gene codes have been found. Do all drugs of abuse have the same background in the brain reward system, the dopamine system? Do they all act similarly? That's an Indian train, by the way, as I adopted that picture. And we must say, yes, in the end, most drugs of abuse have a similar background. All drugs who cause a release of dopamine, especially in the mesolimbic brain area, ventral tegmentum, nucleus accumbens, all these drugs have an abuse potential and act via the same pathways. These reward systems have a place in human beings. They are responsible for reward of food, drink, sex, nurturing. So this is all these care, attention, all these activities increase dopamine release in the reward system, and drugs of abuse do the same, much more faster than drugs do. We know this because there have been experiments starting in the 1950s where needles in animal studies have been placed and the animal pushed a button and released the dopamine in this area. So this was proven in the animal experiment that the brain reward system is important for drugs of abuse. And this is a picture from the NIDA website. As you can see here, the dopamine pathway in the end is essential for all of drugs of abuse. Some do it directly, some do it indirectly via opioid peptides or via GABA system. But all drugs of abuse cause a release of dopamine in the mesolimbic area. And opioids, the topic today, opioids do so as well via interaction with GABAergic neurons. So this is an indirect pathway, but opioids also increase dopamine release. As I said before, we can measure opioid receptors in the brain. There are different ligands in the PET. There's diapirnorphin and carfentanil. This is more specific for that. The different opioid receptor subtypes, I don't have the time to talk into detail. There are mu, kappa, and delta opioid receptor subtypes. For all we know, for the risk of getting addicted, for the rewarding effects of opioids, especially the mu receptor subtype is of great relevance. And as you can see in these pictures here, these opioid receptors are expressed very strongly in those areas where the brain reward system is, basically in the mesolimbic brain area, also in the frontal cortex. There are a lot of human opioid receptors located, not so much in the occipital brain areas or other regions. So these are the central areas where opioid receptors are expressed. The brain reward system is an interesting system. It's not only activated by drug intake per se, I talked about this in the afternoon already, but also the anticipation of a reward. You expect something to do, to drink, to consume, also increases the dopamine receptors, and the brain is firing in this area very strongly because it's expecting and wanting a reward. So it is an hedonistic system, as we say today, that needs to be fed, especially in the addicted. I will talk about opioid maintenance treatment with methadone or buprenorphine in a minute and show you some data about that. That's clinical stuff and relevant clinical stuff. There are always attempts to try to develop some other forms of treatment for drug addiction. Vaccination, immunization would be fine. In the animal model, this is possible. It works. There has been some effects to vaccine against the impulsive intake of heroin, also immunization against the effects of heroin in the brain. The pathway I explained before, opioids indirectly leading to a release of dopamine. If you could cut through this pathway, you would in theory have opioids who have still an analgesic effect, acting at the opioid receptor, but not leading to a dopamine release. In theory, this would mean they would be non-addictive, would be still analgesic but not unaddictive. And to cut through this pathway is being tried in several animal models at present. In the animal model, it works already. Whether in human this will work, nobody knows exactly, but we will see whether this will work. Psychotherapy of opioid dependence, I do not have much time about that. I will be brief. It's difficult to do. You can do it, but you have an enormous rate of dropouts. if you look into meta-analysis about the dropout rates in substance abuse treatment, it's about 40% in cocaine, it's about 37% in opioids, in some statistics it's even 60% or so. The dropout rate doesn't mean the patients complete the treatment, and the long-term abstinence rates is not more than 20% in most studies. I myself have been part in a work group, an international work group for the World Federation of Societies of Biological Psychiatry, a difficult word, and we have published some expertise and guidelines for the treatment of substance use disorders in recent years. One was on alcoholism and the other one was on opioid dependence a couple of years ago. What medications at present are available for treatment of opioid dependence? And this is a wide range now. There has really been a change in recent years. First of all, and still the gold standard, is methadone, usually given oral. It will last for 24 hours. In Britain, they also give it, in some cases, into the muscle. I don't have experience with this, as usually it's given orally. The second option available in most countries is the partial opioid agonist buprenorphine, which in part is available in a combination with naloxone. Naloxone is an opioid antidote which is only acting when giving IV. When it's given in a tablet, it's not metabolized, but it will prevent the patient from injecting the combination, because in this case he would get immediate withdrawal. There is also a buprenorphine film, but not available. Film tablet not available in Europe. Something novel will come probably. That's a depot or implant, a long-acting buprenorphine, currently tested and probably approved in the United States this year. So a depot which will last for some weeks. There will be probably studies in Europe as well. So a depot buprenorphine will be the next novel product on the market. There's also an opioid antagonist available, naltrexone, which is rarely used, I must say, in the treatment of opioid dependence. There's also a depot naltrexone available, not in Europe. In some countries there is some form of heroin substitution for the most disturbed individuals. In Switzerland, this was introduced by public vote, as it is in Switzerland. They vote about everything. They also voted about introduction of heroin, was approved, so we have heroin treatment now in Switzerland. There's another opioid available in some countries, morphine sulfate, but I won't talk about this. What's the principal drugs given in Europe? I don't know how is the situation in Turkey. I took this slide.
There's buprenorphine and naloxone combination in our country.
Yeah,
okay.
That's what my slide is saying. I took this from the European Monitoring Agency in Lisbon, and as it's on the slide says, buprenorphine is used in Turkey, so they were right. Buprenorphine is available in many countries, in Germany as well. It's the leading drug in France and in some of the northern countries, and as I learned just now, in Turkey and other countries, methadone is still the most frequently used drug. Some words about methadone. You know that there's a mixture of the dextro and levomethadone. Only in Germany the pure methadone is on the market, to all of my knowledge. The active, usually it's a mixture, 50% active, 50% inactive forms of methadone is given orally. It blocks withdrawal symptoms for about a day, so it is effective. The clinically alternative is buprenorphine, mostly given in combination with naloxone, also effective for blocking withdrawal symptoms for a day at least. There have been some neuroimaging studies about buprenorphine. Dosing issues play an enormous role, especially when it comes to opioid dependence treatment. We know that 2 milligrams of buprenorphine will block 40% of receptors, 16 milligram 80%, and there's a ceiling effect. Higher doses of buprenorphine won't do much better. 32 milligrams also block about 85% of receptors. So the usual dosages given in buprenorphine is 8 to 16 milligrams, with some tendency at present to give higher dosages. Buprenorphine is quite an interesting drug because the toxicology is in favor of buprenorphine compared to methadone. It doesn't have such a strong respiratory effect as methadone has, so it is in clinical practice, it's a little bit safer than methadone when it comes to overdose risk. What do we know about outcomes? I will skip that. Heroin is also on the market in Germany. Studies. There are multiple studies of methadone comparing buprenorphine. One of the earlier studies were by Johnson and they compared high dose. Methadone high dose was defined on a 60 milligram or more. It's not really a high dose. Low dose methadone, 20 milligrams, and buprenorphine. And it was a randomized study measuring retention rate and opioid use in these individuals. And what they found out was that high-dose methadone, no surprise, was more effective than the low-dose methadone, and buprenorphine was somehow in between, but closer to the high-dose methadone group. Also in the end, both drugs very effective in suppressing withdrawal and reducing the rate of opioids in the urine. I myself have been involved in a randomized clinical study comparing the effects of buprenorphine and methadone and two different arms of psychotherapy. It was a nightmare study. I won't do it ever again in my life, a double-blind study in opioid-dependent individuals, but we did it. And what we're seeing when it comes to pharmacology, similar outcome, just the retention rate here given in methadone and buprenorphine, a little bit better in methadone, but not with statistical effects. So methadone and buprenorphine, both effective in treatment of opioid dependence. There have been a number of meta-analyses and systematic reviews on the question, is methadone and buprenorphine equally effective? I could talk about that for hours. This is an older meta-analysis by Connock, which indicated a somehow better retention rate in methadone compared to buprenorphine, about a 5% difference. This was not much, but in more recent studies and meta-analysis, there's a little bit of a different picture. This is a study by, I think the pronunciation is Hazer, an American author who is a meta-analysis of all available data. And they showed that the retention rate in methadone was somehow higher than in buprenorphine. What is of relevance, and this is maybe one of the important things in my talk, dosing is essential. Dosing is essential when it comes to retention and keeping patients in treatment. In this, I think, important study published in Addiction, the authors clearly showed that the higher the methadone dosage, or the buprenorphine dosage in individuals were, the better the outcome. The better the outcome. Giving too low of dosages of opioids in opioid-dependent people results in treatment failure, dropout, relapse to heroin consumption. You need adequate dosing in those patients, otherwise you will fail. And this has been really clearly shown in this and many other studies. I think that's the most important fact I can show you today. This has also been shown for other drugs of abuse. Dosing is essentials. Finally, some long-term studies. We know buprenorphine is effective. We know methadone is effective. But how's the picture on the long run? All those randomized clinical trials, they go for a half a year or maximum a year. How is it on the long run? We recently published a study which has been conducted a couple of years ago. We call it the PRIMOS study. It was a naturalistic, long-term study about treatment outcome of opioid-dependent patients, patients in treatment, in private practice, in outpatient wards, in GP treatment. All those patients we've seen had the diagnosis of an opioid dependence and were treated in one of these facilities. Treatment aims was, of course, to reduce use of opioids, stabilize health, possibly treat mental and physical concomitant disorders, and integrate patients back in social and work life. What's the outcome of these patients? First of all, we included a great number of patients, about 1,600 individuals. 1,600 individuals, I don't give you the demographics for time reason, but about 1,600 individuals were studied and were followed up for 6 years, and we followed up them for 90% for 1 year and 70% after 6 years. So most of the patients we have some form of information about, an enormous number of patients. And this is the outcome of these about 1,600 patients 5 to 7 years after we have seen them. On the long run, mortality rate is 8% within about 6 years of treatment. So 1% of patients is dying per year. That's much more than you would expect from the general population, but it's much less than in untreated communities. So still a significant rate of deaths, but less than you would expect in untreated patients. After 6 years, the vast majority of patients is still in treatment. 70% are still in opioid maintenance therapy. Most of them on a continuous basis, what we call stable substitution, some in unstable substitution, on and off treatments. They come, they go, they are reintegrated into treatment. But by and large, 2/3 of patients on the long run still in opioid maintenance treatment. So this is a proof for what everybody knows. In most individuals, it's a continuous treatment, a long-term treatment. 20% are not in treatment anymore. Of these, 7% are abstinent. A small number of patients are drug-free on the long run. Some are in treatment, some are arrested, some we don't have much information about, but by and large, most of them still in treatment, and only about 7 or 8% are drug-free at the end. Some scientific data as well. We looked at a broad range of psychological instruments as well. If you are doing substance abuse research, the Addiction Severity Index, that's an interview, there's a composite score. It's not so useful in clinical practice, but when it comes to scientific studies, that's one of the interviews you use, and you get medium values, and several domains are assessed by the Addiction Severity Index: mental problems, family problems, and so on. And as you can see here, when compared to baseline, all the composite scores are better after 6 years. Not dramatically better, but the data indicate you have some benefit, not only when it comes to opioid consumption, but also when it comes to social variables or legal problems, all improve. A few words on deaths. We have patients who die. Most of them die, of course, for drugs. As I said before, that's also the case in this sample. When we look at the data exactly, most of the patients who die are not in treatment at the time they die, and die from various disorders, especially polydrug abuse. Polydrug abuse is the most frequent disorder. So in the end, this long-term study, recently, just a few weeks, published in European Addiction Research, shows a marked and continuous decrease in the severity of the disorder as measured by the Addiction Severity Index. We see a lot of reduction in use of opiates and other drugs of abuse, but many patients still take cannabis or other things. Somatic disorders stabilize by and large. The living and the life situation is improved. Also the legal basis, the criminality is reduced, but there's still some things to do. We have a high rate of psychiatric comorbidity, and patients are virtually untreated. Nobody wants to, from psychiatrists, nobody wants to treat opioid-dependent patients. There's still work to do in these individuals, but we have a good way to stabilize them. As you can see here, we have also in this sample, this is not clear data, but just clinical diagnosis. We have an enormous number of comorbid psychiatric disorders. 40% have a depression diagnosis, 20% an anxiety diagnosis, some are psychotic, sleep disorders are frequent, and so on and so on. Also a lot of psychiatric disorders in these individuals, and there's little effort to treat these patients adequately. There are some certain subgroups which need to be studied in the future in more detail. Male-female differences play a role. There's some interest in pregnancy. In pregnant women to date, methadone is still the gold standard. Whether buprenorphine is an alternative in pregnancy remains to be seen, but to date it's methadone. We know that newborn babies from drug-dependent mothers, of course, are physically opioid dependent. They get neonatal problems. That's one of the subgroup. What happens to these children? They have developmental disorders on the long run. We have more and more aging opioid dependent people. I began to treat patients with opioid dependence about 25 years ago or so. There has been a special outpatient ward in Munich, which still exists. The patients are still there. They are aging as we are. So we have a lot of more and more old opioid-dependent patients. It's not a disorder in young anymore. We have old. And of course, there are many related disorders, neuropsychological problems in these patients. How can they join the workforce, ability to work, ability to drive a car, and so on. All these questions have to be addressed in future studies in more detail. And there are also some somatic problems which have to be studied. When I started to do opioid dependence treatment, HIV was a big topic, still is, but the patients do not die anymore. They have a fairly good chance to survive. A novel challenge is the treatment of hepatitis. Nobody was doing hepatitis treatment in opioid-dependent patients 20 years ago. Now it's a standard treatment. They get the same expensive medication as other people do. Addressing pain treatment in those patients is a challenge. A lot of them have a lot of pain and they are already on opioid medication. Opioids cause a lot of problems on the long run. One of the frequently overlooked problems is osteoporosis. A lot of patients have bad bones when they get older. What we are doing with these patients. And a topic which has emerged in recent years is the QT prolongation, cardiotoxicity, especially related to methadone, but also to other opioids. That's one of the challenges that remain. And in the future, we are hoping to have longer-acting opioids, as I said, depot or implants that would mean that the patient doesn't have to show up on a daily basis anymore, but can come every few weeks. And this may also reduce the relapse risk, at least in those patients who are adequately stabilized. I think I make a point here. It is late. You were a patient audience. I am happy to take some more questions on treatment of opioid dependence. It's an interesting topic. I hope I made this clear. It's an interesting topic. It's clinically there are new challenges. The field emerged over the years. It's not the same 10 years ago and will emerge further. It's an interesting but challenging topic of psychiatric pharmacotherapy. Thanks for your attention. And patience.
Yeah.